Welcome to this explainer, where we're going to demystify high-stakes nephrology. Today, we are acting as clinical judges, strictly separating true actionable signal from diagnostic noise. Look, in the fast-paced environment of acute care, it's incredibly tempting to just react blindly to an abnormal lab value, right? You see a low number, you want to make it higher. But as we're going to see, reacting without auditing the underlying physiology can lead to absolutely catastrophic mistakes. So we're going to break down the exact physiological tipping points you need to know to safely navigate sodium, potassium, and acid-base emergencies.
And that brings us to this haunting mnemonic, from low to high, your pawns will die. It perfectly represents our overarching goal today, which is learning the rigid physiological thresholds that prevent lethal clinical mistakes. If you take away only one single thing from this entire explainer, let it be this. In renal management, speed is rarely a friend. We have to respect the body's osmotic boundaries. So how exactly do we systematically avoid these pitfalls?
Well, here's our roadmap for the audit. We'll be hitting 4 key areas: the osmotic audit, the tubular divide, the cardiac defense, and finally, the ultimate intervention. Let's dive right in.
Starting with Section 1, the osmotic audit, hyponatremia physics. We start with the classic 50-50 dilemma of hyponatremia. A clinical lawyer just notes a low serum sodium and automatically orders fluid restriction without a second thought. But a true clinical judge demands a strict audit of volume status and urine electrolytes. When you calculate a serum osmolality below 275 milliosmoles per kilogram, you absolutely must differentiate euvolemic SiADH from hypovolemic extrarenal losses. Oh, and a borderline low serum uric acid? Honestly, that's just noise. The true signal you're looking for is that low serum osmolality coupled with a high urine concentration driven by ADH.
Now, the absolute crucial tipping point here is the urine sodium. A level below 20 milliequivalents per liter tells you there's maximal aldosterone activation in a hypovolemic state. Think about it. If your patient is hypovolemic from, say, severe GI losses, their kidneys are desperately trying to hold on to every drop of sodium. But in a completely euvolemic SiADH patient, you're going to see a urine osmolarity well over 100 and a urine sodium greater than 40. This single number totally flips your management from giving isotonic saline to restricting free water. It's literally a game changer.
Because if you get this wrong, the consequences are devastating. Correcting chronic hyponatremia, meaning a sodium level below 120 faster than 8 milliequivalents in 24 hours, is a huge preventable mistake. Blasting them with rapid-fire hypertonic saline causes this violent water shift right out of the astrocytes, which precipitates osmotic demyelination syndrome. We're talking irreversible flaccid paralysis and dysarthria. Remember our quote? From low to high, your pawns will die. When sodium drops and stays low for a few days, the brain adapts. Overcorrecting literally shears the myelin sheath, specifically in the central pons. It is absolutely devastating, and it requires a strictly disciplined correction rate.
Okay, moving on to Section 2, the tubular divide, renal tubular acidosis. When we're evaluating a normal anion gap metabolic acidosis, or NAGMA, we have to map out the tubular transport barriers. The diagnostic dividing line is really fascinating. Type 1 represents a distal hydrogen secretion defect. Because the acid simply can't get out, the urine pH gets trapped above 5.5, and that alkaline environment aggressively drives calcium phosphate stone formation. Now, type 2, on the other hand, represents a defect in proximal bicarbonate reabsorption. So initially, yes, the urine is alkaline, but once the systemic bicarbonate stores are utterly depleted, the intact distal tubule finally does its job, and the urine pH drops below 5.5.
Which brings up an interesting question. What happens if you just try to fix type 2 RTA by giving standard low-dose oral bicarbonate? You'd logically think, hey, the patient is acidotic and low on bicarb, I'll just give them some bicarb, right? Well, no. The damaged proximal tubule is going to immediately reject it. This right here is a classic execution gap in acute management.
Because spilling that filtered bicarbonate directly into the distal tubule drastically worsens potassium wasting, inadvertently causing profound hypokalemia. Since the proximal tubule is defective in type 2 RTA, any fresh bicarbonate you give just washes right past it. And as this heavy load of negatively charged bicarbonate floods into the distal tubule, it acts as an unabsorbable anion. It literally pulls positively charged potassium out into the urine just to balance the electrical charge. So you try to fix the acidosis, and you end up triggering a massive, super dangerous potassium loss.
Which is a perfect segue into Section 3, the cardiac defense, hyperkalemia vectors. Let's talk about the structural pathway for managing these hyperkalemia vectors, escalating all the way from simple intracellular shifting to definitive cardiac defense. Potassium essentially dictates the electrical stability of the heart. As potassium climbs above 5.5, the electrophysiological tipping point slows conduction velocity sequentially. It predictably morphs the EKG from peaked T waves all the way down to a fatal sine wave pattern. First, you'll spot these uncomfortably tall peaked T waves. Next, the PR interval stretches out, the P waves flatten, the QRS widens, and finally, it slurs into a sine wave pretending imminent cardiopulmonary arrest.
So when we're auditing these labs, we deploy a rigid severity invasiveness resuscitation matrix. If they're stable, meaning potassium is between 5.5 and 6.0 with a totally normal EKG, you can use oral potassium binders like patiromer or intravenous loop diuretics. But in emergent cases, where potassium is over 6.0 or you see literally any EKG changes, your immediate move is intravenous calcium gluconate to stabilize the myocyte resting membrane potential. It doesn't actually lower the potassium, it acts in minutes to build a shield around the heart. Finally, critical cases with refractory hyperkalemia and anuria or a persistent sine wave require emergent hemodialysis.
But beware of this shifting pitfall. A classic dumb mistake here is assuming insulin and dextrose actually clear potassium from the body. They don't. They merely shift the ions intracellularly for about 4 to 6 hours. You give the calcium to shield the heart, and you give the insulin with dextrose to swiftly shove those ions into the cells. But remember, that is just a temporary bandage. In 4 to 6 hours, that potassium is going to leak right back out into the blood. Your job isn't done until you proactively initiate loop diuretics or dialysis to achieve true total body clearance.
And that brings us to our final module, Section 4, the ultimate intervention, emergent hemodialysis.
Let's conclude our clinical audit by looking at the absolute criteria for pulling the trigger on emergent dialysis. The formal indications follow the famous AEIOU rule. These represent the absolute most severe refractory metabolic complications your patient can face on the ward. We are talking about severe metabolic acidosis that won't budge, dangerous electrolyte imbalances like the refractory hyperkalemia we just covered, toxic ingestions, massive fluid overload causing pulmonary edema, and finally, severe uremia.
Now here is the real executional pearl to take away from this explainer. Do not delay while waiting for a specific chemical blood-urea-nitrogen threshold to validate what is happening right in front of your eyes. If you put your stethoscope to their chest and hear the grating sound of a uremic friction rub from pericarditis, or if the patient is confused and suffering from uremic encephalopathy, the threshold has been met. Period. You must place that dialysis catheter immediately, totally ignoring whether the BUN is 60 or 160. The true clinical syndrome trumps the isolated lab value every single time.
In the incredibly high-stakes environment of acute care, relying on these rigid physiological tipping points rather than rote memorization is what truly saves lives. We've covered the critical boundaries today, from respecting the exact osmotic limits of the brainstem to anticipating the tubular spill of bicarbonate to actively defending the heart's electrical grid. So, the next time you look at a comprehensive metabolic panel, ask yourself, are you relying on true clinical signals, or are you just reacting to diagnostic noise? How will you audit your very next lab panel? Thanks for joining me in this explainer, and keep questioning the data in front of you.